All right. So back to something more sort of conceptual. So let's say you're developing a reputation for being a single payer activist, and your local legislator who actually has aspirations for wider political office, let's say that person sees you on the street or in the elevator somewhere and says, well, I don't really get it. Like, we already don't have a good choice in the United States for insurance. We seem to not have a good choice, and now you're taking away the choices we do have, and you're going to leave it at one. Is that really something we really want? Don't we want to have choice? So if somebody said that to you, what would your response be? How do you think about that question? Srinidhi, do you want to lead off and take a stab at it? Some sort of response. How do you think about it? Did you even, maybe you wanted to ask the question yourself, how do you really want to get rid of choice of insurance companies?
Yeah, I don't know. It's like I mean, we've been talking about it all this time. I feel like it's such a nuanced and like complicated conversation. I was trying to think about what I would say while you were asking the question. I don't know if anybody else has a thought about it. Or Dr. Malek, do you have any thoughts that we can kind of expand on?
Okay. Zach, do you want to say something?
Yeah, I think what we've heard like Dr. Weisbart say or things like that when people pose a similar question is just like people don't necessarily care about choosing their insurance company. They choose more about choosing where they get their care. So they want to be able to go to whatever hospital either is closest to them or that they think is the best. And that choice is maintained under a single payer system, is what I would say.
Let me rephrase that, Zach. You're saying that you could say back to the patient, do you really want to choose an insurance company, or what you want to choose your doctor and hospital and then hope it'll be covered well? Like, would you be willing to give up your choice of doctor and hospital, or would you just choosing an insurance company? Is that really what you want to be choosing? Is that what's important to you?
Yeah, that's what I was trying to say.
And you could go on to point out that Medicare includes 93% of the doctors in the country, whereas insurance companies have narrow networks, in ghost networks where somebody's on the list as a mental health provider and they're not even available. They don't even exist, or they don't have available appointments. So, the narrow networks are actually at insurance companies, not in the public programs. Little problem with that is Medicaid, since they would accept almost any provider pretty much who's properly credentialed. However, because the reimbursement rates are low, a lot of doctors then refuse to accept Medicaid patients. So that's a problem, but Medicaid itself would accept any doctor, whereas private insurance companies, they have these narrower networks. Okay, so another question is, responding to that, what are you could say to the person, well, did you have a choice? Like, what were your choices? And let's just say they're under 65 years old, they literally may have had very few choices. Like, if they're getting insured through their job, did somebody say to you, oh, here's the 3 insurance companies you could choose from? Very few people have that anymore. I haven't had that in 25 or 30 years from the job where I could actually choose. The most I was able to choose within a certain company, that all the offerings were the same insurance company. It's usually been Blue Cross of Vermont. And I could choose the HMO plan or the high deductible plan within Blue Cross. And then over time, the HMO plan, which was supposed to encourage preventive care and not have co-payments for primary care or for a pap smear, that kind of thing, that got worse. And so now there's like deductibles and co-pays even in the HMO plan. So everything is merging into, you know, generally crappier coverage in all the plans. The high deductible plans tend to attract the healthiest people, leaving ever sicker people in the HMO plan supposed to, you know, have lower co-pays and all that. So they have to make their coverage worse so that they don't end up with all the, you know, the sickest people. So competition among insurance companies is, in a sense, an inherent failure, and we're going to actually talk about that more this afternoon. The notion of a market failure. But anyway, people have they really had choices? Now, if they are over 65, they do have choices. And if you're talking to somebody who's over 65 who actually says that, I got on the Medicare website, and there were all these choices in Medicare Advantage plans, and supplemental plans if they don't want a Medicare Advantage plan. And there's no way to, I'm telling you, there is no way to evaluate those choices. Like United Healthcare had 4 or 5 different plans within Medicare. There are sort of different clauses in their Medicare Advantage plans, and there end up being 4 or 5, you know, little extra choice of doctor, a little less choice in some of the others, and they're a little cheaper. But it's like, you know, these are your choices. You know, 5 versions of United Healthcare, 3 versions of Humana. The patient can't possibly understand, doesn't understand, you know, really realize the implications, and it may not even matter that much whether they're paying in the form of a higher premium or, you know, limiting their choice of doctors. It's kind of a zero-sum game. You give up a choice and you get a slightly lower premium. So it's you know, these choices I think you can say to a person, don't you just want really good coverage without all these deductibles and co-pays, and to be able to go to the doctor you want when you're sick? And, you know, and that's really what people generally want. And contending with the current insurance system is not a very satisfying way to try to accomplish that. So looking at that again, one thing you could start out with is, how many of us actually have a choice among insurance companies? Do we even understand the choices we have? For example, on the Medicare website, do you think that any of those Medicare Advantage plans that were on that list told me in making the choice what percentage of care they denied and what percentage of how many prior authorizations they required last year, or how many of them were denied? That data is not available. So, you know, the type of choice you have is a little hollow, and many people, especially under age 65, don't even have a choice. You know, and frequently none of your choices are very good. And I think you can say that to people, and they're gonna have to agree, because that's what we've got. Anyway, so that's one question. How about if somebody said, well, in Canada they ration care, and, you know, and everywhere else they ration care. South Korea, you know, who knows? Nobody knows about South Korea or Taiwan or any of these other places. But they say, oh, they can't get care. We have the best care here in the United States. We don't want to go over to a system, you know, a Stalinistic system, rationing. How would you respond to that? Lauren, what would you say?
I might pull up like data about outcomes. Because I think based on that, America does not have the best healthcare. Um, but um, I also know that some people are more persuaded by data than others, so I'm not really sure what a good way to go about it would be actually.
And Srinidhi, go ahead.
Yeah, and I think building off what Lauren said, I think bringing up data is a good point, but also even if we compare like within the US, like with Medicare, like you were saying, if you're over 65 versus outcomes when you're younger, there's a clear difference already. And I think the biggest like complaint people have with these other systems is the wait times that are long, but we have long wait times in the US anyway for a lot of specialty care. So I think that it's an argument that you can easily kind of give evidence to show that it could still work here in the US.
Yeah, there's that slide that Dr. Weisbart brought up showing that once people get onto Medicare, our healthcare system performs pretty well, and they have good life expectancy at that point. And before that, it was very poor, contending with what people under 65 years old have to face in the U.S. Go ahead, Zachary.
You can tell me if this is something people are receptive to, but I would illustrate to them that we already ration care as well, but based off of your ability to pay. So I'd bring up maybe a story instead of a data of like if a low income person gets diagnosed with cancer, they might forego treatment because they don't want to go bankrupt and they just might accept that they're going to die when there might be a viable treatment option. So I think that might be an example that I could connect to of how we ration care in the United States.
And you could ask, how have you found it easy to find a primary care doctor? And very few people do find it easy. You can call that rationing. You can't get an appointment. You know, that sort of amounts to the same thing. Inanna, go right ahead.
I feel like if I'm stereotyping the person that might be saying this and that they're very patriotic and pro America, freedom. So I think I would say something like, well, one, wanting to have access to adequate care isn't like radical, it is American, and we can look at our other capitalist democracies like Japan and Germany and Switzerland that all guarantee healthcare for their citizens, but they also aren't giving up innovation or personal freedoms or anything like that. And then I would also, I think, turn it back on them and be like, if like what others have said, if we truly had like the best healthcare system, why do people have to hold GoFundMe's to fund their medications and prescriptions? Why are medical bills one of the top causing of personal bankruptcies? And it's not like our goal isn't to copy other systems from other countries, but to find out what works best for ours and what works best for everyone and allows everyone to have adequate access to care without breaking the bank.
Right. So I guess there's two approaches to the question. One is to talk about what goes on here in the U.S. It's complicated. And the other is to talk about what goes on abroad. So you could say, yeah, Canada, when they've looked at wait times, and when you're studying other countries, that might be something you read about. When you look at wait times internationally, Canada, for emergency procedures, Canada does actually a little better than the US. They pretty much get done in most developed countries. But when you're looking at elective surgery, Canada does the worst internationally among the various countries for a number of elective procedures, ophthalmologic and orthopedic, like cataract and hip replacement. Canada does worse. US does better than that, and Northern Europe, they do a little better than the US. And, you know, when you're looking at other countries, you know, you could look up South Korea, see how they do. And I actually thought, Lauren, that you might say, well, you know, I studied South Korea, and none of what you're saying is true. There really isn't rationing. They spend a third of what we do per capita, and they live longer than we do by quite a bit. And it seems to me that we should look at them, and maybe they could be a model for us, because, you know, people do get the care they need there. And that's not unique. If you look at Spain and Italy, Sweden, you know, other countries, we actually do worse. We have worse outcomes. We spend much, much more and get very little for our money. So I think, you know, accepting the premise that, yeah, some countries do worse. England has many years has done worse. Canada generally does worse. And then most of the other countries do a lot better. Any other thoughts on that question? All right, well, how about this one? Can we afford to have single payer reform? Like, it seems to me it's going to break the bank. We can hardly afford what we have, which involves not ideal treatment for a lot of people. Seems like that would break the bank. We already pay so much taxes.
I don't have a well parsed out thought, but I think I would emphasize, like, yes, you're right. We can't afford the system we already have now. Like, the percentage that the US spends on the percentage of the US's GDP that's spent on health is greater than any other country, and it's growing at a faster rate. So I think I would start off like that. And then I'd mention reducing administrative costs by having single payer. And then probably something about like negotiating drug prices. Yeah. Yeah.
So a single payer system would be in a much stronger position to reduce input prices for cardiac stents, for prescription drugs, hip prostheses, everything that you're buying. You'd have a strong negotiating power to deal with prices. That's what you're saying, right?
I think so. Yes.
Yeah. And if you want to get more complex, you could say, well, with all those insurance companies, the hospitals have these bloated billing departments, and they can only recoup the money they're spending on that by padding it onto your bill. So the hospital prices go up because of high administrative activity in the US. So all these prices are way too high because we have complex, inefficient system with multiple insurance companies, all of which add to administrative costs and all of which are in a weak position to negotiate down prices. So, you know, enlarging on your point about prices. Trinity, why don't you go ahead?
Yeah, and then I think adding to that, like I think a lot of people's concerns are very much on the I don't want to pay more taxes. And so I think bringing it back to like on a personal level, like you already pay so much in insurance premiums, and that cost will get redistributed to what's going to be taken out of your taxes. It's not that as an individual, you're going to be paying those insurance premiums that are really high already, plus more in taxes. And so overall, it wouldn't be as bad as like on an individual level, the cost of having single payer.
Yeah. So, Inanna's argument, and to some extent your argument, are a little theoretical. Just you could also give a more empiric answer that all the other countries, they actually do spend less than we do. So if we adopt their system, why would we suddenly pay more when they're all paying? The ones who have accomplished that reform are spending less. And Inanna already told you why, in theory, that should be less costly. So I guess I'm having trouble when you could say to the person, I'm having trouble with the premise of your question that we would spend more. Seems to me we would more likely spend less. However, Srinidhi, I want to raise a different thing based on what you just said. I think one of the things that you might sometimes want to say to someone is, and this picks up on what you just said, that you're already spending a lot in taxes. And to lay that, you could go a little further and lay that out. Like, as a taxpayer and a healthcare, somebody who wants to have health coverage, let's look at what you're paying for now. You're paying your insurance premium. If you actually get sick, you're going to probably have to spend a lot of money on co-pays, co-insurance, that kind of stuff. And you're paying for the whole Medicaid program, which you're not even going to take advantage of. And you're paying for the Medicare program, which you're not 65 and you're not disabled, so you're not taking advantage of that. You're paying for care for everybody in the country who's blind because they're all covered through the government. You're paying for everybody with end-stage renal failure because they're all covered by the government. You're paying for the Indian Health Service. You're paying for the VA. You're paying for the military. You're paying for the postal workers. You're paying for the Transportation Security Agency. You're paying every time you go to Walmart because a portion of their money is going to go to healthcare. So you're already paying for healthcare in so many ways. Why not get rid of all that complexity and say, well, you could be paying for yourself and everyone else. We could all pay and simplify the whole thing and simply give everybody covered instead of picking out these categories and covering them one at a time in this incredibly administratively complex way. So you could sort of bring that together. And when you think about an uninsured person who pays taxes, it's amazing how many other people they're paying for, and at the end of the day, they get nothing. Go to the doctor and have to get the bill paid. So have to pay, have to pay their own bill. So yeah. Anyway, let's see what else I came up with. All right. Do you really trust the competence of government to pull this off and create an effective, functional single-payer system? Government is always incompetent, doesn't do anything right. How about that one? I got nobody. Mackenzie, it's your turn. Put yourself on the line. And again, if you give a bad answer, it's execution. So you better do well.
I think that's a difficult one because there's not, I think, a really concrete way to point at it and say like they will do a good job. I think because it's especially a lot of feeling. Like I can't remember who exactly it was. I can't remember his name, but he worked in one of the health insurance companies is like, it's not by accident that people don't trust the government. You know, like we have a vested interest in that being the case. So I think that's really embedded in a lot of people. And I think sometimes they have pretty good reason. I mean, with the current administration, I wouldn't trust them with my healthcare, but I think pointing to the fact that right now our healthcare and how much healthcare we get is in the hands of like insurance companies and private equity and people that we know for sure don't have our best interest at heart. And the fact that we're not only allowing them to control our care, but we're paying them a very, very good amount of money to deny us care. But at the same time, I think people might be more comfortable with the devil they know than the devil they don't. So I think that's a really hard one. I don't have a very good answer for it.
I think that is a very good answer. I think it's a very good answer. I think we are trusting ourselves to predatory capital. You know, I have to tell you, turns out that 60% of the nursing homes in Vermont, and probably a high percentage in other states, are owned by private equity capital or other for-profit entities. And okay, so you're going to take your grandmother to a company that you know has a track record of having higher death rates, lower nursing staffing in nursing homes. And, you know, it's very problematic. There are, you know, doctor practices opening where they sell out to private equity and can't provide the care they feel is important. So I think that's actually a good answer. I want to divide your comment, though. I want to take Trump out of this for a moment and then put him back into it. Just taking Trump out of it, I think you could get into some of the issues in designing some of the issues we didn't really get to in designing a healthcare system. And that has to do with one issue could be accountability. That you can have a system that covers everybody, and that's in the system. And I mean, that may be too abstract a concept for a brief interaction with someone else. But let me just say, on more of a policy level, it's very important to include a system of accountability in whatever your proposal is, so that people really feel they can organize systems of actively soliciting feedback when you design a healthcare system, so that it could be accountable, as opposed to for-profit companies and private equity, where you know that you're going to have no impact and there's going to be no accountability. So I think that's it sort of gets back to kind of the same thing. But but there's a completely different type of answer that's not related to McKenzie's, and that has to do with okay, so you think government couldn't do it well. So you're saying that you'd rather have insurance through United Healthcare than through Medicare. You trust the insurance companies not to deny care you need. Is that what you're saying? And you could contest it more widely. You could say, well, actually, I think the government's doing a great job in the health sector. The National Institutes of Health does some of the finest research, is the leading research institution not just in the US, but in the world. The FDA has a process that prevents unsafe drugs from going on the market. Do you want them to stop? They're actually doing that, and it's really important work. And the CDC before Trump was, you know, very effective in identifying disease outbreaks and alerting the public, alerting the other doctors through its publications, MMWR and other publications, of what's going on, so that doctors know what to look for. So I actually feel really proud of the government, and what we've done has actually gone really well, as opposed to private insurance companies, which keep raising their rates. And you know, how much accountability do you have there? So I don't know. I think you can actually defend government's performance. Trump's cuts have not been based on any rational assessment of agency performance. They've been more ideologically driven. I think everybody knows that, even in the political right in the country. So I think McKenzie's point of looking at, okay, you don't like government, who are you actually going to get? That's in one argument, it's a good one. And then, is government's performance really been so bad? Do you want to get rid of the FDA? Do you really want to have no research going on? Is this, do you really don't like the NIH? Tell me what you don't like about it. So anyway, I think those are options. Do you really not want to go on Medicare when you turn 65? Do you really not want to have a Medicaid program so the poor people can't even get any care? Like, what is it you want? Like, you're making this sort of pat criticism that Mackenzie pointed out as being, a whole lot of people want us to believe that the private sector does everything better, and there's tons of propaganda in that direction. And I think just taking it on directly is, one option for you. And for someone who's really into policy, you can say, and yeah, we're gonna, the goal is to build accountability into the system so that the public system can continue to do better than private equity control over your healthcare. All right, let's go to the Trump thing now. Okay, same question basically. Okay, so you got your system, everybody's getting healthcare, and then Trump gets elected. Do you think he cares? Like, how are you going to make the system function in the face of Trump, who just doesn't cut everything? All right, well, let's go back to the system on designing a healthcare system. The question is that we face in designing the system, can we create a Trump-proof, successful single-payer system? And if you recall, we talked about governance as one. So again, if you're following Jerome Powell at the Fed, control the banking process. Trump said he should step down, and he hasn't stepped down, and he hasn't given in to Trump on anything. And I don't know, I think this is an important political event for you to really fully understand. So does everybody know what's been going on with Powell and the Fed and Trump's attacks on Powell? You guys, you might not be news junkies the way I am. Anyway, Trump keeps saying Powell's terrible. He's an idiot. He's just the stupidest person at the Fed we've ever had. Trump actually appointed the guy 4 or 5 years ago, but that doesn't stop him. Anyway, so he's at the Fed, and they're supposed to set interest rates mindful of trying to get to full employment, but keep the inflation rate around 2% and not more, and actually not less. That's their target. And that makes sense for a variety of reasons if you're going to have a capitalist system. Anyway, so right now, with all these tariffs, it's a threat to the economy, and it's a threat for inflation because everybody has to pay more to, because of these tariffs adding to the cost of imported products. Anyway, so Powell says back, we're not doing it. We're going to keep these interest rates the way they are. If the hit on the economy is greater, we'll lower interest rates. If these tariffs end up causing inflation, we'll raise the interest rates. And that's what we're doing. I'm not stepping down, and you're not affecting what we're doing. And the key to this story is that every time Trump starts attacking him, the more serious Trump's attacks are, the market goes down, the satisfaction with Trump goes down, and he backs off. And so let's move this over to a single payer system instead of the Fed. So number one, what Jerome Powell has behind him is a term in office. It is going to end in about 10 months, and he will step down because it's a democracy, and he believes in democracy. And his term ends, and he's going to step down, and they'll then reappoint. Somebody else will get appointed. So you can design, we talked about this, you can design your system that the governance of your system is going to have a commission where there's, say, 7 people on the commission and they each get appointed in a subsequent year. So in each given year, only one person's appointed. You could have the appointments come from not just politicos, like in the political sector, but you could say there's going to be a position for doctors. You know, if the AMA can decide on a position, they could even have some sort of voting process among doctors. You know, there could be an input from other employees. You got to remember, this is only going to happen if we have a progressive government. This is not going to start during the term of a conservative. So you started off so that the nominating process is going to put people on there who actually want to have a high-functioning health system. And they come from circles, you know, from a background that would want that, like a doctor. And so, and maybe, I don't know, a hospital administrator, you could give a few appointments to employees. There's a few federal agencies where there's like half the employees are appointed by Democratic politicians, half from Republican politicians. You could do that, but I wouldn't give every seat to that process, because you're just going to end up with, you know, only politicos. So anyway, you can, and then stagger the appointments, like I just said, so that each year there would be only one new appointment. And, you know, have some sort of commission structure. Like, I actually don't know how the Fed makes their final decision, but it sounds like it's semi-consensus process. And so the commission could, you know, flesh out a position on something or other, and then, you know, and then enact its decisions. So the other part of it, which I mentioned for Powell, is that what Trump's doing isn't popular. It's not popular in particular with investors. And so every time Trump attacks Powell and the Fed, the stock market drops like, you know, 300-400 points at least. And so the inherent popularity of the existing system of controlling interest rates is preventing Trump's attacks from being successful. Trump has completely failed in his attacks on the Fed. They haven't given in an inch. And the point is, single-payer health care isn't generally very popular. And so when it's attacked by the likes of Margaret Thatcher in Britain and the Conservative Party, they don't take down their insurance system. The Conservatives have been in power about half the time over the last 25 years in Canada. They don't get rid of their insurance system. Every Canadian still has the very same insurance they had before the Conservatives. And that's because the system is popular. It's considered a treasure. So people love these systems. And so the point is, you're going to create a system that's going to be shielded or have some, armor to prevent attacks especially from someone like Trump, who's, and it's beyond ideologically driven. It's just almost more nihilistic. I almost feel with Trump, you should just tell him, well, why don't you just take credit for the single payer system? We'll name it after you, and we'll call it the Trump American single payer system, and then he'd be happy. So, I mean, he's a little different, but most of this is going to be more like previous Republicans who are getting, you know, campaign contributions from people who in the private sector who are making a lot of money. And so you have to create a system that's relatively, you know, a little bit protected from those attacks. And you can do it. Not going to be perfect. But. And during Cameron and the other conservatives, the system never gets bad. They don't make it better for the most part, but they generally don't do a whole lot to make it worse. Yeah, Zachary.
Couldn't you also just say, like, do you think our current system is Trump-proof? Like, he's making all these cuts to Medicaid, and, you know, they're saying 50,000 people are going to die and rural hospitals are going to close en masse. So can you even say that this system is Trump-proof? And I don't know, like, if someone wants to mess something up, I feel like, especially if they're the president of the United States, they can do a lot of things to mess it up. So what even is, like, I don't get the criticism. Or maybe put that in perspective.
I actually think that's a really strong argument. That you can basically say, if the electorate is going to put someone like Trump in power, then they have to deal with the consequences. You know, you give him power to this guy, you don't, he didn't say he was going to take down the entire healthcare system, you know, and disrupt rural healthcare in particular. He didn't run on that, but, you know, it's turning out that's his policies are. I mean, he really forced that bill to pass. He twisted a lot of arms to get that legislation through. So I think it's his baby now, and you know, he's, you know, it is what it is. I don't know. Anyway, any other thoughts on all this stuff? I think I have one more, and then we will adjourn. Pull down and stuff. What I thought of. Okay. People smoke, and they don't take care of themselves, and they eat too much, and they're all overweight. And that's the problem. That's why healthcare costs. They eat too much, they get diabetes, they smoke, they get lung cancer. And then I'm supposed to pay for it. I don't want to pay for that anymore. Like, you know, they're making our healthcare systems really expensive, and you know, and that's the problem. Bad behavior. I don't want to pay for their healthcare.
I think I get that. It is frustrating that people aren't taking care of themselves, and it feels like other people's poor choices might raise your personal costs. But we all, as humans, face health risks. There are people that did everything right, didn't smoke a single cigarette in their life, didn't take a single drink, and still end up with cancer or dementia later on in life. Like, these things just happen. And so I think even those who make unhealthy choices also do those in the context of trauma and poverty and other systemic things. And I think we could help that by at least giving them some sort of a safety net in terms of our healthcare system.
Mackenzie, before you go, I just want to say something about anonymous response. The first thing you said is a really good thing to start with. And and I haven't done that anyway here, but I should have. You started out by acknowledging the impetus, the flavor of the person's frustration. And that's a really good way to start for really any of these answers. And for each of these questions, you actually could. You know, like, for example, the question on, you know, wouldn't this cost too much? And you can say, yeah, I'm frustrated by high healthcare costs, but let's really look at this more carefully. So the first sentence, in general, when you're having a discussion with someone who, for the most part, people don't understand all this stuff. I mean, you're in this program for 5 weeks, and you're going to come out with the beginnings of an understanding, a strong start. But still, you know, if you even go to your medical school, how many of those people are going to know much of any of this? So people don't know a whole lot, and so just acknowledge their feeling and the sentiment. It's frustrating that the costs are so high, and it is frustrating to pay for a lung cancer surgery in a smoker. But, and then, you know, you got to take your answer after that. So Mackenzie, go right.
And this is just to like build on what Anana said, because I also really liked your answer. I think other things that I think of when people say that would be to say something along the lines of, you know, like that people, you know, with diabetes or who have a weight problem, you know, stuff like that. One way to ensure that they're able to continue to be a part of the workforce and part of the economy is to make sure that they have, you know, some level of healthcare, either preventative or in response to current conditions. So to make sure that they can contribute to the economy and not just necessarily like be receiving like your tax dollars or, you know, something like that to, you know, kind of feed that back into the system, like an approach, something like that.
You're getting toward an ethical statement. Somebody made a bad choice. So let's give an example. So say cancer of the pancreas, which is more common in smokers. So in other words, you could say back to them after acknowledging, again, starting out with Anana's beginning, which is what we really should be doing for all of these. So we start out with Anana's statement and then go on to say, okay, so they caused their problem and now they're dying of it. So you want to say, you can't afford hospice, but because you caused your disease, we're not going to help you. You can just die in pain and without any help. I don't think you want that. So why don't we just start with people where they are, try to get everybody to improve their behavior through public health, you know, through messages and, you know, availability of tobacco cessation drugs and whatever else, and, you know, get the messaging, tax the cigarettes. But to deny care to them, I mean, you must have a relative who smokes. Do you really want them treated like a piece of dirt if they die because of their tobacco and not treated with some sort of dignity? I don't think you want that. I don't want that. So Mackenzie's idea is more ethical, and you can appeal to basic decency of people, and I think that's good. I got more answers. Anybody think of other answers? Trinidhi, why don't you go?
Yeah, I agree with what both Anana and Kenzie have said so far. And then I think one of the points Kenzie mentioned is like more access to preventative care. And I think emphasizing that people will have early access to avoid things like even with diabetes. Yeah, a lot of people have diabetes, but there's a large population that go undetected with diabetes for a really long time and then it gets too bad. And then obviously the costs are higher. But by people getting like preventative care more frequently, which they would if there was single payer, just because they'll have more access and they're not concerned about how much is this going to cost. We can like kind of cut costs by nipping things in the bud sooner, and that way you're not paying for people's bad behavior quite as much if you frame it in that way.
Right. Okay, good. Zach, what are you thinking about?
I don't, maybe this is just how I think about things, but the idea of like cross substance, like basically like private insurers subsidize uninsured care. So no matter what, even if you don't want to pay for this person, you're going to pay through it through increased premiums. The more people we have like this, if they're uninsured and they go to the hospital and they're in a diabetic crisis and they get completely uninsured care because they have to care for them with emergency care. And if more of those people exist, then that money has to be recouped somewhere, and it's typically recouped from private insurance companies increasing their premiums to subsidize that care. So maybe like increasing awareness that regardless of whether or not you want these people to get care, they are going to get care, and you're probably going to be the one paying for it. Just maybe not through taxes, maybe through a way that you're more like receptive to, like insurance premiums, but it's still paid for by you.
We ultimately all pay for everything. The difference is in a single payer system, it's direct. You know, I pay taxes, you get that care. Of course, I get the care when I'm sick too, so there's that. I just want to say a little bit more on this same question. So when this person says that to you, okay, so you want people who are overweight to pay more taxes. And what if they were 180 pounds overweight last year, and this year they lost 20 pounds, and now they're 160 pounds overweight? Is there ever a point where you stop charging them more, if that's what you're trying to do? or not cover obesity-related conditions. Like, what if they're doing better? Like, what if they went from smoking 2 packs a day down to, 1 pack a day or something like that? They're still smoking. They're smoking less. Like, and what if they quit smoking and then 5 years later got lung cancer because your risk is higher for several years to get a malignancy from smoking? So would you not pay for it because years ago they smoked? Like, aren't you adding a lot of complexity? Like, are you going to create a surveillance state to see exactly how much everybody's smoking, and if they're chewing tobacco, like, are you going to measure that? Like, how are you going to measure? What if they're choosing to use an all-terrain vehicle or a dirt bike rather than going snowshoeing or, something like, or hiking, doing something healthy? Like, you don't like how they use their recreational time, so you're going to penalize them too. Like, how far are you going to go with this surveillance state? And what if people lie about, yeah, I go hiking every weekend, and actually they spend the weekend on a dirt bike, and letting the motor do the work. So, is this really enforceable? Is this what you want out of a healthcare system, is to create a surveillance state where people are trying to figure out every behavior? And you can't really include all the behaviors because a lot of things people could do better at. Like, yeah, you ate a carrot, but you didn't eat any other vegetables the whole day. I'm penalizing you because you need to start eating broccoli. It's like, where does this end? This intrusion. And so, and I think you can say that to people and it kind of works. Like, it's completely unenforceable. Like, I don't. I mean, the idea is so unworkable. Coming up with a systematic way to somehow penalize people. And what is it you want to do? You want to say that they can't receive health care in a single payer system, or you don't even want them to get care. Let's say we don't have a single payer system. What do you want to do with these people? Why don't we just try to get their behavior to improve? Like, maybe if we stopped advertising snowmobiles and had people talk about snowshoeing, maybe people would choose healthier exercise in winter. It's like, I don't know. Hiking never gets much advertising. It's always, vehicles and unhealthier things. I don't know. So, we're sort of cultivating bad behavior, and then we don't like it, when people actually do it. How many commercials are there for, like, water as opposed to drinking beer? It's like, I don't know. Where does this end? This sort of, using some sort of, punitive system to not get people covered. So I just feel like, you go to the doctor, they hopefully nag you about the appropriate things, and sometimes it's effective. There's a statistic that if somebody goes to a doctor and the doctor says, you should quit smoking, that 7% of the time they'll actually quit smoking just when the doctor said it. So is that a 93% failure rate, or are you actually getting millions of people to quit smoking? If 100 or 10 million smokers went to the doctor, and then 7% success rate, then 70,000 people would be quitting smoking. That would be nice. So, getting people access to healthcare, and then if the doctor prescribes, appropriate drug, they might even have a higher quit rate. So it's, keeping them out of the system is not ideal. Anyway, go ahead, Zach.
I think to your point also, if you do want to kind of give in to like their nihilistic idea that certain people shouldn't get care because they're like too much of a burden, you could instead like frame it as like, okay, if you want to like make sure these people are paying their fair share, then we can put a sugar tax, we can put an increased, tax on cigarettes, and we can have those taxes contribute to the health insurance like the health insurance system. And that's not something I'm necessarily advocating for, but if you want to just walk through this thought experiment with them, I think that could also be an effective way. And I think other countries have like sugar tax or junk food tax that they already implement, or even some like cities in the United States.
Yeah, I actually support that strategy. I think we have tobacco taxes in the U.S., and they're effective. They're especially effective for young people. So yeah, I think taxing behaviors you don't like is, that are unhealthy is a good idea. I still like, you can say all these things, do you really want a surveillance state to enforce this, is your agenda, are you gonna put broccoli into it or just cigarettes? You know, like, what are you gonna include, what are you gonna exclude? So when you get into that, most people will, you know, look upon what they're saying as pretty unworkable, and it's like, you know, come on, let it go. Let's just take care of everybody, not add administrative complexity, keep the system simple, and help people to behave in a better manner. And, you know, many people smoke because they're depressed or they drink too much. So let's get to that by getting them into primary care and identifying the depression. That's, fueling this unhealthy behavior. But I do like to go back to Mackenzie's answer, because I think it's nice to, I just like the psychological effect of saying to people, do you really want to not have people who've behaved badly? You really want to cut them off and just throw them in the street, or do you want to be a little humane, even if somebody screwed up? And I think I think it's a good thing to include. Any other thoughts? Kind of interesting how all these questions are sort of multiple approaches. But I think a none is paramount, to start out by acknowledging the sentiment the person is having that got them to ask the question the way they did. That's mandatory, and I haven't been doing it in my answers, but I'm glad that she did, so we could all see it in action. And I think acknowledging what people are saying is really useful. All right, so any other questions, or we can adjourn, and I guess we're meeting again at 1. All right. I hope you found this helpful. Take care.
Thank you.
Thank you.